Thank you. So I'm going to talk briefly about, it's a bit difficult to see the slides and talk. Is that fine, the sound? Oh, they're down there. About participant protection and data governance around research using routine electronic medical records from a health information exchange here in the Western Cape. And my collaborator is Prof. Andrew Bull, who's the PI who's built that. Right, sorry. So the Provincial Health Data Center is an African health information exchange. It's here hosted at the Department of Health in the Western Cape province. It contains data for about 6 million live individuals, about 12 million individuals in total. And we gather routine electronic administrative records for individual patients from a variety of resources. And we link all those data to a patient master index. We have a unique health ID here in the province. So I have to give you a quick overview. It's a lot to take in, but otherwise I run out of time. So apologies if it's a bit speedy. But the way the data flow works for this database, I call it a database, but actually it's a series. I think we're on about 9 or 10 databases, is that we collect data from all these different resources. We have electronic platforms in the hospitals, primary healthcare. We get laboratory data from the NHLS, which is our national laboratory service. We get dispense data from our chronic dispensing unit, as well as individual dispense data. The population register data is still a bit of a wish list, and that's a whole other story. But these data we also get from disease information systems. So we have the TIER database that is particularly for HIV health services. And we have, for example, an electronic TB register. All the data come in every night, and they're rolled up into the data center. So people call it Health Information Exchange Data Center. Some people call it a data warehouse. You can call it whatever you like, but it's a centralized holding space for all of those data. And then the end use is primarily for patient care. It's for ensuring continuity of care, ensuring that clinicians have a full medical record that is province-wide. We have reports, care cascades. We define medical conditions through our episodes. We build alerting engines. So, for example, our first one that we did was flaccid paralysis, which is an indicator maybe for potential polio. So when we automatically identify that in our database, there's an email that gets sent to appropriate people to investigate. So the whole aim, we also do epidemiological analyses and business intelligence and management type data sets. The whole aim is really about health service, strengthening and improving patient care. And then right at the bottom right, sorry, I don't think I have a pointer that works. You can see the academic research is really at the bottom of our priority list. This is just a high-level architecture in case any techies in the audience, but I suspect maybe not in this particular audience. So it just shows how we roll up the data and produce our episodes, encounters, and cascades, and then present them to end users through reports and other mechanisms. So using these data for research, this is an amazing data resource. It's updated as of midnight last night. So if somebody went to a facility yesterday, it will be in the data set. So we have longitudinal data for all healthcare clients who go to public health resources in the Western Cape. It's laboratory data, pharmacy data, healthcare encounters. It's extremely up to date. I think our worst lag is maybe up to 2 days for some data resources. And we can derive this information around burden of disease, we can identify patient outcomes, and we can identify, importantly, the gaps in care. So the cons of using PHDC data for research is that when somebody goes to a government facility, they go with this implicit agreement that they're giving over their personal data for the provision of health care. They don't give any consent for research or secondary data use. It's not even part of the conversation. They're visiting a doctor or nurse to get health care. And we also have a second problem, and that is because this is not an electronic medical record, it's actually administrative data mostly. So this is not about having a complete coverage of everything. There are big gaps in the data, and if you don't know the data well, you can provide very, very misleading analyses of the data. So it's really important to have a good knowledge of what the data can and can't show. The can't show is just as important. We also wanted to know, what do healthcare clients think about the use of these data for research? I don't have time to go into the details of this analysis, but one of our public health registrars did a focus group discussion study at 3 facilities, 52 individuals, and they explored a whole lot of these different questions around what did the healthcare clients think of the use of their data. I pulled some here, but we really can't go into them in detail, but I did pull out the really important messages from the patients and from their perspectives, which I think are really relevant here. So the patients absolutely, and I want to call them healthcare clients rather, they believe that they own their own data. They don't believe that the Department of Health gains ownership of their data. They believe the data are their own data. They also believe that within the trust relationship, they are very clear that the data are collected to provide healthcare and not for any other purpose. And then, interestingly, they very strongly felt that the data could be used for research only if, and absolutely clearly only if, specific consent is requested for every study. And they strongly felt that broad consent was not sufficient for the use of these data in any kind of research. So how am I doing for time?
We still have time, 10, 12 minutes.
Okay, great, thanks. So the challenge about using these data, the challenge is to respect the healthcare clients, to respect their privacy, but also to improve health outcomes. So we really try and promote equity by finding this balance. And one of the ways we do that from within the data centers, our primary aim is to benefit the participants, to benefit them through improved health and well-being. So we really are not interested in promoting people's research careers through provision of health data for publications in nice journals. We're interested in research that actively demonstrates a benefit to the participants who provided those data. And we balancing beneficence and risk. We prioritize research because we feel there's a lot of risk in the use of routine health data for research. And we prioritize research if we're going to put our participants in any kind of risk, it must be balanced by demonstrable benefits for those participants. So, and for the health service that provides those people with health care. So we prioritize research that most directly benefits those who are put at risk through participation. And especially because so much of we don't have consent for research use for these data. So that little helicopter crossed out was because we absolutely don't support helicopter science, which is where people swoop in and scoop data sets and disappear and have absolutely nothing to do with our health service, our province, our participants, or anything around, related to those. So the data governance, we have a very well-developed data governance structure. We have SOPs and defined processes for people who wish to access research data sets. And we have 2 different streams. One is operational data, what we call operational data sets, or requests, and then we have research requests, which are considered separately. And the difference is operational research requests. These come from within the Department of Health, so healthcare providers who are either hands-on providing direct healthcare or who are involved in the health system. And under our POPI, which was mentioned earlier, it's very similar to the GDPR. The Department of Health is a responsible party for these health data, and the operational requests come from the Department of Health. So it's the same responsible party. We don't pass the data to a different responsible party. And the data use remains the same. This is also under POPI and also under the ethics. The implicit agreement with our healthcare clients is that the data are used for the provision of healthcare to those clients. So if it's within the health service, for strengthening the health service and for providing individuals with better healthcare, it falls within that remit. And then we keep, for operational data requests, the data sit within the Department of Health. They don't leave the secure service. So operationally, the data are very well protected and the risk is absolutely minimal. So for research requests that come from outside the Department of Health, we have also very defined sort of structure. So some people request aggregated data, and these obviously reduce risk to individuals. However, we believe that we've taken a number, it's fairly arbitrary, but a sort of pragmatic choice of a number of 20. If data aggregate to below 20, we won't release those data. We'll ask the data requester to choose a bigger enumerator area, because we believe the risk of identifying individuals increases the fewer of those individuals fall in the aggregated reporting. For individualized data, those data might be identified or de-identified or anonymized. If the data are identified, we check for IRB approval, and we also check for informed consent that's been obtained for individuals to receive, for us to provide data on those individuals. And when I say we check for informed consent, we specifically read the protocol that was submitted to the Ethics Review Board, and we read the patient information that was provided to the participant, and we read the informed consent templates, and we make absolutely certain that when an individual consented to this study for which data are being requested, they knew exactly which data would be requested, they knew it would be requested from us, and they knew what the intended use of those data would be, and that they agreed to all of that. So that's the only circumstance under which we would release any kind of identified data to a researcher outside the health service. For de-identified data, we're very cognizant of the fact that you only need a couple of data points to be able to re-identify health data sets. So there are some circumstances where we might agree to release de-identified data, but we practice quite extensive data perturbation. So for example, an epidemiological study, we would only give a year of birth of individuals, we wouldn't give a date of birth. And if it's a study that needs dates, we would add or subtract an undisclosed integer to all the dates, so that the time between dates is still epidemiologically relevant or correct, but the actual dates can't be used to re-identify an individual by going back into folders. Obviously we obfuscate facility names and take out any kind of personalized data. So we really work very hard to change the data in a way that it's not possible to re-identify data sets. And then we do also offer a service which we're growing slowly, which is acting as a trusted third party. So when data sets get combined, two anonymized data sets can potentially become re-identifiable when they're joined. And we have set up a structure under which if people want to join two data sets and then have it anonymized and data perturbation undertaken, the Department of Health Data Center is able to act in that trusted third-party role. So we have the paperwork and the MOUs and all of those things where we can make a very well-defined process where we can act as a secure third party to combine data sets, anonymize, undertake data perturbation, and provide a combined data set that's not identifiable. So I think that's pretty much all I had to say. Our future directions. We want to look at informing healthcare clients about potential data research, data use for research. Initially for posters, brochures, waiting room media, and there's quite a push from healthcare clients to have access to their own health data, which we would like to be able to facilitate. We'd like to provide under the current structure, an opt-out mechanism. So if people don't want to be in anonymized research data sets, they have the right to opt out. And when I say anonymized, I mean anonymized, de-identified, cannot be re-identified. because currently that's the only unconsented use of individualized data. And then in the long term, we'd like to actually get proper tiered informed consent for primary research, secondary use, and also to get specific informed consent around recontact for future studies. And maybe to be able to use that kind of process to flag eligible, for clinicians, flag eligible participants to approach them and see if they're interested in other studies. Thank you. So these are my collaborators at the data center. Andrew Bull is the PI and is quite visionary in putting the data center together. And all my colleagues who are all the data analysts, we sit in the Health Impact Assessment Directorate, who are very supportive of the process, and all our various funders. Thank you.